Thank you everyone for joining our symposium, the Real World AI in Healthcare joint symposium between AIM-High and HAIP. Thank you, Mark. I'm Matt Solomon. I'm a cardiologist and physician scientist at Kaiser Permanente, Northern California. I'm on the team coordinating the AIM-High program. Just a quick word about AIM-High. It's the Augmented Intelligence and Medicine Healthcare Initiative, which is a Gordon and Betty Moore funded program coordinated out of Kaiser Permanente, Northern California, which seeks to advance research methods, identify best practices, and build capacity for effectively implementing and rigorously evaluating the use of AI and ML algorithms for clinical decision-making in the real world. And the KP AIM-High Coordinating Center selected a portfolio of 5 projects at various healthcare systems across the country that are evaluating the implementation of AI in real-world settings. And we're thrilled to hear about one of these projects today. So on behalf of AIM-High and HIIP, it's my honor to introduce both our speaker and faculty discussant for today. So first, let me introduce our speaker, Dr. David Ouyang, who is an assistant professor in the Department of Cardiology and the Division of AI in Medicine at Cedars-Sinai Medical Center in Los Angeles, California. David is a cardiologist focused on cardiovascular imaging and a physician scientist and leader in the field focused on AI applications in cardiology. Dr. Ouyang works on applications of deep learning, computer vision, and large language models on large data sets within cardiovascular medicine. And as an echocardiographer, he ran the first blinded randomized clinical trial of AI in cardiology, comparing the performance of AI assessment versus sonographers on measures of echocardiogram in a prospective blinded assessment. His work has been published in Nature Medicine, and JAMA Cardiology, and he is also one of the inaugural deputy editors at New England Journal of Medicine AI. Dr. Ouyang majored in statistics at Rice University, obtained his medical degree at UCSF, and did his postgraduate medical education in medicine cardiology and a fellowship in computer science and biomedical data science at Stanford. We're thrilled that David was selected as one of the AIM-High grantees and look forward to his presentation today. It's also my pleasure to introduce Dr. Rohan Kara, who's a cardiologist at Yale University, where he leads the Cardiovascular Data Science, or CARDS lab. He's also the clinical director of the Center for Health Informatics and Analytics at the Yale Center for Outcomes Research and Evaluation, and an associate editor for the Artificial Intelligence and Digital Health at JAMA. So without further ado, I will hand it over to Dr. Ouyang for his presentation.
All right, Matt, thank you for the really kind introduction. And really glad to be here. I know that this is the start of the symposium series, so very excited to be the first speaker and looking forward to have a great discussion with Rohan as well as the rest of you guys over the course of, this year. So our project is titled High-Throughput Precision Identification of Cardiac Amyloidosis in Diverse Populations. We'll really focus today both at a high level, what is the background, what is the clinical need, particularly in cardiac amyloidosis, and then kind of our approach to using computer vision and AI for screening of cardiac amyloidosis. And really this will focus in 2 parts, one on the algorithm design and 2 on the prospective trial that is now finally underway. So I like to start my talks often with something even outside of cardiology, which is actually a picture that was published in the New England Journal now more than 10 years ago, which to me represents that common phrase, a picture is worth 1,000 words. I think that it really highlights that there's a lot of information because in this picture, rather than the disease, the New England Journal published a picture of a truck driver. Over the course of maybe 20 or 30 years, you can see that he might have gotten asymmetric sun exposure, which speaks to the environment as well as his inheritance. Maybe he's Caucasian. That leads to a phenotype that we can see. The left side of his face looks different from the right side of his face. At the same time, we need imaging to interrogate this, and whether it's visual imaging by a picture or echocardiograms or ultrasound, CT, MRI, or chest X-ray, it all remains the same. But the reason that we as clinicians and patients care about this is because it has an association potentially strong with clinical outcomes, right? For this gentleman, potentially his risk of skin cancer is different from the left to the right side of his face. And I think that that's something that we can readily tell from the imaging features. The challenge that I would pose, and I think that that's why I think there's a lot of value in imaging, is that a lot of this information is lost in the distillation layer that we call the EHR. No matter how thorough of a clinician or how detailed of a note writer, it's very unlikely that you capture all the results. It's very unlikely that if I were to see this gentleman in clinic, that I would give enough kind of space in the note to really describe the features or the asymmetry in his face. And maybe in a dermatology clinic, you might see some evidence of this, but maybe in a way that really reduces a lot of the signal and distills it into noise. As a cardiologist, I think that this really speaks to the opportunity with AI. Because even though as a cardiologist, I know many measures, ejection fraction, coronary calcium on CT scans, delayed gadolinium enhancement or SCAR on MRI, these are all human-derived features, right? And we care about these human-derived features because they have a strong relationship that goes to the clinical outcomes. But really, it's the tip of the iceberg. There are, even for things that we take for granted now, say 20 years ago, DGE was not well established. And how we assess ejection fraction when there was only B mode echo maybe 40 years ago is also very different from how we assess ejection fraction now. How that imaging is interpreted will change. And it will most certainly change with AI because it's an opportunity to really evaluate these measures and even potentially come up with new measures. As we transition here, I like to start with I would say, patient story. This is an 82-year-old gentleman with a history of heart failure, preserved EF, atrial fibrillation that's undergone AFib ablation, 6 sinus syndrome with a pacemaker implantation, and a history of a left wrist carpal tunnel syndrome that required a fasciotomy. In 2019, he underwent an extensive workup for just not feeling like his usual self, more out of proportion shortness of breath and dyspnea on exertion. And you can see that on the top right, I list that he's actually was hospitalized a few times and underwent quite a few echoes interpreted by many different cardiologists in a short amount of time. And I think that now that there's more interest and more awareness, there are some features that might be concerning for cardiac amyloidosis, while maybe if you were to look at it on a holistic level, doesn't quite meet criteria. In cardiac amyloidosis, one is known to have low voltages on EKG. However, neither by limb leads nor by precordial leads does the EKG actually meet criteria. Maybe if one squints in retrospect, this is actually some EKG that might be suggestive of cardiac amyloid, but at least certainly at the time was not recognized. And on the right-hand side is actually a parasternal long axis view of his echo, where the sonographer measured his septal wall thickness as 1.3 centimeters and his posterior wall thickness as 1.3 centimeters as well. Again, hindsight is 2020, but if you look at potentially the septum, where the sonographer traced the septum, maybe if I were to say it looks a little bit ungenerous, that you could actually equally move the arrows here and here and potentially get a higher wall thickness measurement that might also be more consistent with cardiac amyloid. This really speaks to, in the broader community and in academic medical centers, cardiac amyloid is underappreciated. The incidence of diagnosis of TTR amyloid in the United States is on the order of 7 to 10K cases a year. Yet, we do about 8 to 30 million echoes a year. Where, if I had to say, the literature and how we evaluate it in a variety of other metrics suggests that there should be many more cases of amyloid that can be diagnosed. The incidence of just positive PYP tests, so bone scintigraphy, for another reason, non-cardiac reasons, if you were simply to get it for a bone indication, has about a 1% positive for cardiac involvement. The estimated incidence in aortic stenosis multiplied by the incidence of cardiac amyloid in aortic stenosis would also suggest that there should be 20K cases. And similarly, if you estimate the number of patients that have heart failure with an increased left ventricular wall thickness, multiply that by what the literature suggests is the incidence of cardiac amyloid in these patients with LVH, similarly would suggest that there are many more patients to be identified. So ultimately, the thought process is that there's a diagnostic chasm, and really the best place to find that unmet need is echocardiography, because it's the top of the funnel. Cardiac ultrasound or echocardiography is really one of the first tests one gets if someone has shortness of breath or heart failure symptoms. There's rarely a patient with heart failure that doesn't have already received an echo. and is an area where there's a broad base of understanding of many features, but maybe insufficient sensitivity nor specificity when interpreted by human readers. That leads to the challenge where, at least currently, it takes patients about seeing 4 specialists, roughly 2 to 3 years before an initial diagnosis of cardiac amyloid prior to the initial symptoms. It's an area where this is unfortunate because there's actually many new targeted therapies, both for cardiac amyloidosis as well as phenotypic mimics such as hypertrophic cardiomyopathy, really subtyping the patient well and identifying the population in a way that's actually definitive and well determined is actionable. There are many therapies that are even in the pipeline that can drastically change the morbidity and mortality of these diagnoses. So in our work, and this was published in now 2 years ago in JAMA Cardiology, we started working on an algorithm to use echo to evaluate for cardiac amyloid. It's a 2-step algorithm, which I'll walk through, but broadly speaking, a cardiac ultrasound or an echo study has on the order of 50 to 150 videos. We first identified the right videos to do measurements. So the wall thickness is often measured on the peristernal long axis view. And then we use an AI computer vision model to actually evaluate the wall thickness for every single frame and every single beat of the video. And you can see 2 representative examples where the model annotates are the 4 heat maps in different colors, green, purple, blue, and yellow. And the measurements of wall thickness are actually what's being calculated between these heat maps, between these points. Because it's a beat-by-beat measurement, it allows for more precise measurements that can be averaged across multiple beats. And this is something that we've shown in some of our earlier work with ejection fraction, that the more frames and the more beats of a heart one calculates, the more reproducible measurement it is. And also, this model is able to actually capture the wall thickness in a way that many other algorithms fail when there are challenging or low-quality images. So both of these are considered relatively high-quality images, but on the right, what I want to show for the cardiology in the audience is that there's actually a pericardial effusion. So if you look under the posterior wall, there's at least a moderate, maybe even a large effusion, but our AI model does not confuse that for, say, the posterior wall or in terms of our measurements. This is something that when you have many limited or few training examples, is easily confused by an AI model. We show that kind of when we actually use these measurements, it actually allows for more reproducibility. And this is actually done at 3 different centers where we actually trained the model on echoes from Stanford Hospital and evaluated the model on held out test set from Stanford, held out test set from Cedars-Sinai, as well as a Unity, a publicly available data set from the British Heart Society that actually has annotations of wall thickness. In all of these measurements, the AI model for wall thickness allows for more precision in the identification of wall thickness. And you can see this based on the scatter plot of what the model predicts versus the reference measurement on the study versus what is the human reported measurement when it's compared to separate studies of the same patient over time. When we found the set of patients that said no significant change and saw how different do the wall thicknesses or measurement change, we did notice that there's actually more spread and more heterogeneity even on the same images, even on the same patients. After identifying patients with left ventricular hypertrophy or thick left ventricular wall, we then actually identify the etiology of the LVH, of which we know cardiac amyloidosis, hypertrophic cardiomyopathy, longstanding hypertension, aortic stenosis, and a variety of other causes can actually all cause a similar feature. But we do recognize that at least even prior to AI, there's a well-known literature that the texture of the myocardium is different in patients with cardiac amyloid, especially on earlier echoes without resonance imaging. In this model, we had an AUC, or after identifying the patients with LVH and selecting matched controls, we had an AUC of around 0.8 in identifying cardiac amyloid and around 0.9 in identifying hypertrophic cardiomyopathy. The reason why you like to highlight that this most certainly isn't the model with the highest AUC that's been published, but it's a model we're really proud of, is because this 2-step algorithm actually prevents shortcutting, by which I mean that if you only identified or train a model on age and sex matched controls, you actually can easily shortcut on hypertrophy, such that a model isn't really identifying the features of cardiac amyloid per se, but identifying when there's a thick wall of muscles, which is a much easier task. We show this on the far right, is that if you were to actually train a model on age and sex matched controls, and instead of cases of amyloid, show them cases of AS or HCM, so they would actually confuse those with amyloid. But if we use our approach where we actually use aortic stenosis and ACMs as controls, it's much less likely, very more strongly discriminates the difference between amyloid versus other types of LDH. Even with this model published, we recognize that this is still very far from clinical deployment, clinical application, right? We published a paper now 3 years ago, which showed that as we looked at what it took to get FDA approval and what were the commercially available algorithms, we saw that in some ways, the bar for FDA approval is not the end all be all. For the algorithms that have been FDA approved, very few have been validated on many sites. Now the FDA is actually a little bit more stringent in wanting multiple sites in the evaluation. But there are many algorithms approved just on retrospective data from one site. The vast majority are only evaluated on retrospective data, so previously collected data is sufficient to clear a AI algorithm. And there are very few clinical trials of AI. And I think that that's really what I think the symposium is all about. But at the time of our analysis, we saw that for AI approvals, none of the technologies that have been FDA cleared actually have undergone prospective trials with blinding or randomization. And I think that, as the clinicians in the audience will know, those are really I would say, the foundational elements of a clinical trial that we use to judge whether a trial is good or not. If there's the Hawthorne effect, if there is easily confounding, or if there's many other variables that can happen with just retrospective data that can falsely amplify the impact or the efficacy of an algorithm. So as part of the kind of AIM High initiative, we're really excited to actually be evaluating this algorithm at 4 sites. And I'll walk through kind of what our process is. We are actually looking at historical echoes. So roughly getting, or I'll describe the sites in a little bit, or for each site, we'll get the historical echoes from the last 3 years. And then we'll actually screen or run the algorithm on all those echoes. For example, at Cedars, this is the retrospective piece is done. We evaluated on echoes from 2019 to 2021. This is close to 100,000 echoes. And then we create a histogram. The histogram is the probability of cardiac amyloid, where 0 means the algorithm thought it's very unlikely, and 1 means the algorithm thought was highly suspicious for amyloid. And we had a predefined threshold of 0.8 as our threshold of when we think it's suspicious enough that we want those patients to be followed. And those patients are the ones that we're actually planning to see in clinic and actually evaluate if they truly have amyloid that have been misdiagnosed. And I'd like to show this figure of the retrospective data, which just shows that kind of, on the top right is actually all the outputs of the echoes being screened. The vast majority of echoes are unsuspicious. But when we look at the suspicious echoes of greater than 0.8, and we were purely to color it by actually proportion, all of the known amyloid in our center are actually highly enriched at that threshold greater than 0.8. And by which I mean known amyloid are the patients that are actually seen in our cardiac amyloid clinic, so that we actually have a list of patients that are on kind of these targeted therapies or have otherwise undergone heart transplant or other definitive treatment for cardiac amyloid. But even in that high subset of patients that are really suspicious, greater than half do not have a formal diagnosis or are not seen by our cardiac amyloid clinic. And I will say that kind of as an example, so again, this is prior to the prospective piece, we chart review these patients. And you'll see that in the dark green are the patients that actually are seen by amyloid clinic. Surprisingly, in light green are actually many patients with amyloid, but maybe only seen by hematology, or maybe being seen by other providers in the healthcare system, or maybe an outside cardiologist that are following them. So they weren't followed up in our cardiac amyloid clinic. A good number have unfortunately passed away, or kind of, since 2019. But there are a good number of patients that we do want to see, screen and evaluate. So in yellow are a couple of example patients where the chart review actually looks suspicious, and I think we are currently enrolling. You can imagine kind of the one-liner briefly written here is it's a 100-year-old with severe LVH, moderate aortic stenosis. It's an 85-year-old with mildly reduced ejection fraction, very severe LVH, or it's a couple of patients with diagnosed HFpEF and LVH, but no confirmatory testing that had been done for cardiac amyloid. So as part of the AIM High kind of, I would say, initiative, this is a 4-center clinical trial where the Cedars-Sinai, the Palo Alto Veteran Affairs Medical Center, Northwestern, as well as Providence Heart Institute in Oregon, are going to look back at the studies that they've done for the last 3 years, scan through the images, and then identify the patients that are high risk, so at that 0.8 threshold or higher, and have them seen by an amyloid specialist. And those are patients that ultimately, will let the physician decide if they think deserves additional downstream testing, whether that's with a PYP scan or cardiac MRI or other testing. But our primary endpoints are the number of patients that are newly diagnosed with cardiac amyloid, and we're quite excited to see, obviously how many patients undergo treatment, get enrolled in a clinical trial, or get therapeutics prescribed for cardiac amyloid. I will end with one last slide, which is the highlight that really this is the vision that I have for echocardiography, right? It's the top of the funnel for almost all forms of cardiovascular disease. And this is a figure not focused on cardiac amyloid, but really speaking that even for many of the other diseases that we care a lot about as cardiologists, such as mitral regurgitation, the ability to scan through many studies and reevaluate them at high throughput is something that we're particularly excited about, and we hope is an opportunity to improve care in terms of quality and in terms of early diagnosis for patients. All right. Well, thank you for the opportunity to be here, and really looking forward to the discussion afterwards.
Thank you so much, David. That was excellent. I'd like to turn over the discussion to Dr. Rohan Kara, who's an assistant professor of medicine and biostatistics at Yale University and the director of the CARD lab, as well as the Center for Health Informatics and Analytics. And we are very grateful to have Dr. Kara here with us to begin to lead this discussion about your work.
Perfect. Thanks again for having me here. It's always fun to hear David dissonant. So, and I would start off with a couple of observations. First, I'd say, we're certainly at the beginning of a new paradigm in cardiovascular diagnostics. And, David only mildly hinted at it, but the idea that we would be pursuing diagnostics the same way, where somebody will eyeball an ECG, somebody would eyeball an echo and do some manual measurements, and that would be the norm for our diagnostics, is likely a very short-lived future, a past that we'll certainly go away from it. And David has certainly led the charge in that domain. And I feel the other thing I would clearly mention that the work has, for me, highlighted one aspect, that our focus on clinical criteria can be questioned and likely should be questioned. The hope that we can do, low voltage on ECG and pick up everybody with amyloid is probably not going to work. And I think that's some of the genesis of our underdiagnosis is this reliance on our traditional age-old criteria to diagnose disorders, especially where there are treatments and where it can actually change the course of patients' lives. So I feel there's a key reason to not, stick with the age-old. And I think David did a terrific job with the JAMA Cardiology paper in 2022, highlighting that we can go really far and look at the same images as a human, but go pick up the elements that others can't see. I also want to take a moment to talk about David specifically, because I think before I get to questions, I want to say these questions are prefaced with the idea that, David, as young as he looks, is a leader in our field. And this is a deceptively young-looking person, is a leader in our field, and in a few ways, not only does he do thoughtful science, which I think, he should be given credit for, but he does it and, he sees it through. And the work that he's done so far, going from retrospective studies, going to prospective studies, is actually making the entire field a lot better. And then, then he's done other stuff, as a community and a scientist, he's released data to help others. Thinking about Echo AI as a field that would be nascent without the EchoNet dynamic data set. And I think, there's credit where it's due. And then I think, from my perspective, David's an excellent, generous collaborator and pushes you to be a better scientist. So I think I do want to say, whenever I ask a question, David, those are the things that I keep in mind when I'm asking those questions. So in disclosure, I've actually, we've built AI ECG tools in parallel for ATTR cardiac amyloid. Those tools are currently under FDA review. There's a breakthrough device designation to one of them. So I have a conflict of interest, but none that overlap with the science that is presented. If anything, I'm actually more invested in what we discussed today. The first thing I want to sort of bring up for conversation, and I don't want to like speak for a long time and not let us listen to David, is where are we sort of headed next in this diagnostic paradigm? So, we've been doing a lot of work, and I don't want to get to the tough questions first. Where are we headed, tough in like subphenotyping amyloid? Like you were able to pick up HCM, AS, and amyloid. Where are we going? Because the therapeutic options vary pretty substantially with the type of disease that you have. So where do you think we're headed in terms of imaging-based phenotyping to help us go further?
Yeah, Rohan, you're one much too kind, and definitely we love to highlight that fact that your work in kind of using EKG images is really, really, truly top of the funnel, right? Obviously, there's many people that get echoes, but the opportunity to get EKGs from patients that aren't even seeing a cardiologist is really top of the funnel for a lot of these therapeutics. For me, a lot of our approaches are, I wouldn't say limited, but upper bounded by the labels we have, right? I think that obviously for cardiac amyloid, there's many subtypes of TTR and AL are just the most common. The ability to more precision phenotype patients really reflexes actually, I think, more closely with kind of a lot of the work that Rohan does, which is kind of identifying the right patients for the right clinical trials. I often think of the clinical trial as the way to reflex on which patients should get certain types of diagnostics because you need to pair the diagnostic with the therapeutic, right? I think that
That's true.
online, I tweet that like obviously there's a lot of great multimodal cardiac imagers out there. We do CT, we do MRI. There's many different ways to evaluate things like ejection fraction. But I'm partial to ejection fraction, not just because I focus on echo, but because that's actually how we enroll for a lot of heart failure trials. The heart failure trials are enrolled by the echo EF. So if it's the comparison of how best should we assess EF, I think inevitably you got to go closest to what the clinical trials show.
That's an excellent point. And just to sort of generalize that entire idea, the hope that we phenotype and subphenotype diseases should not be dissociated from their like actual use in the practice. Like having 5 phenotypes which are treated the same way and are just prognostic is probably not helpful for our, just making that process better. And I think, the more challenging questions. So I might get to the more challenging aspects of the talk. So, I am certainly bought on this idea that we need to diagnose diseases better, especially something like amyloid, which is overrepresented in our minority populations who have less access to care. So how do you grapple with the idea that even with the estimates of prevalence that you have so far, and even with excellent performance in the echo models, how are you going to ever get to the point where the screening tests reach performance that is sufficient that we can actually, I think this is a burden. I'm trying to grapple with 2 aspects here. The false positive rate in these tests is likely to be high with a model with a AURC of 0.97. It's going to be about positive predictive value, the term how many positives versus total tested, true positive versus total positive, is likely to be around the 10% range at the best end of the spectrum. So how do we grapple with that reality when we are trying to increase the pipeline of these possible positives?
Yeah, that's a really great question. And I think that it really digs into the weeds of how we design this prospective piece. Ultimately, that 0.8 threshold that we chose in terms of a model output much more preferentially chooses specificity over sensitivity. And I think that, this is contrary to what I think a lot of people would say is the canonical wisdom for screening tools. But our concern is that for a lot of these screening tools, we will have a lot of positives. And then to get buy-in from the broader community, I think that the people who've chased down those positives are more interested and more invested if it has a very high PPV, right? We know the classic story where like even for mammography, you'll be more negatives than positives, even with a very highly, I think, performant test. And that's a situation where I think can be even more, I would say, limiting with AI because there's so many concerns or I would say kind of qualifications around it. That really we wanted to choose a threshold in this trial to really be at a place that we think can drive engagement. I think that that very much can change over time, and as these things get more adopted widely, we can look at the literature that many screening tests might actually be more sensitive, and that might be a place where I think that we might be able to tolerate more in the future. But definitely for a prospective piece, especially if we don't want to chase down too many patients for adjudication, preferring specificity now.
Perfect. That's an excellent, thoughtful way to design the study. So how do you see, do you see any, in your work so far, have you encountered the fact that those who are lower on the probabilities? So again, we set up thresholds so that we maximize specificity, but that's going to create a range of people who were traditionally positive on the test, how it was originally conceived, and who are now, in this intermediate range. So have you in your work encountered that these individuals are different than the ones that are positive at all? Or are they all all distribution and there's no like qualifying feature that makes the 0.9 on the probability scale different from the 0.5, while you might have set a threshold somewhere at 0.6?
Yeah, it's a really great question. I don't think that we have done that analysis, and I think that we do need it with a little bit more granularity. Part of the limitation has been that our sample sizes of the positives are small. So I think that, we've definitely done subset analysis at different thresholds, but so much of that I worry is more within the range of, random statistical noise than true differences between populations.
Perfect. I mean, I think that's definitely, worth area worth exploring. The next question that I want to pose is this idea that each positive currently requires radiation exposure. And have there been like some, and you've interacted with folks who like, and again, you and I don't treat amyloid primarily, I can safely say that. But there are others who like spend a lot of time thinking about these patients and how they were treated. Has there been some alternative strategies to, do an intermediate test that allows us to reduce the radiation exposure even further to, even like enrich that pipeline further?
Yeah, no, it's a really great question. And, particularly for cardiac amyloid, there's multiple downstream tests that can give more suspicion, right? There's actually has been historically, and not now, but post-COVID, a shortage of technetium. So actually getting the PYP test was hard. We've actually, some of the centers will reflex to cardiac MRI. So no kind of exposure to kind of either kind of GAD or no exposure to radiation. And also is or at least on the T1 mapping, also a very specific test. I think that depending on the society guidelines, some places will say that that's sufficient to clinch the diagnosis. Other places will still want, say, a biopsy or a PYP to confirm that testing.
Okay, perfect. I mean, I think that's very so in your I think the natural next question in this arc is that doing single center studies is easy. You know your center. Most of us have essentially like been here in our centers for a while, so we know the IT infrastructure, we know the clinical workflows, and so an externally validation and external sites. How did you navigate both aspects, the technical deployment and the clinical integration? And if you could talk more about that, I think everybody here who's thinking about AI deployment will really learn more about the process and doing it well.
Yeah, clinical trials are hard, full stop, right? I think that that's where even with a really good therapeutic, you need to drive the right amount of excitement and engagement, both on the patient level as well as the provider level, to really go anywhere. And I think that, we published a trial for LVEF that was so much easier than our amyloid trial because the outcome happens on the order of seconds to minutes rather than actually having to get a downstream test and having patients seen in clinic. For our trial, we've supported every site on the technical piece, just so that there's harmonization in terms of how the data is processed, how the algorithm is deployed, but really have focused on having site-specific champions that actually handle more of what does it look like in their center to screen for amyloid, to see patients, and what kind of conventional testing they would want afterwards. so that actually the way we've designed this is very pragmatic. Each site has an IRB. It's not an umbrella IRB, so that we actually have small changes or small questions that each IRB asks. Then we try to harmonize those. And it's very much a pragmatic trial where we'll meet to really talk about challenges that coincide across sites. But we'll notice that we pragmatically would say that the trial is just to follow up what happens when they are seen by clinicians, but we don't want to dictate what the clinicians does with this information or what kind of testing they do downwards.
Perfect. I think that that certainly makes it more practical and especially cost effective in this, in this early phase of this work. The other question that, often comes up, especially for rarer disorders, we build our diagnostic tests or the screening tests in populations that were already tested. And sometimes sometimes that's a large enough population, something like EF assessment, so that you have sufficient distribution of populations. But herein we have like smaller test population, as you mentioned. How is the design of the study built to ensure that we are able to pick up at least cues that the model may be failing subpopulations that were otherwise not represented before in the true labels? So if the minority populations were not present among your true people population, like high enough percentage, and now the screen positives are largely them or screen negatives are them, how do we ensure that that doesn't change the performance is definitely not driven by those people who were testing differently in validation versus in development?
Yeah, no, that's a really good question. It's something that we're trying to be particularly thoughtful for. A lot of our limitation is for cardiac amyloid, the small numbers, although recognizing that there is kind of increased underdiagnosis in, I think, minority populations. Because of the small numbers, we've done cursory, but haven't necessarily thought that the numbers were big enough to do true subset analysis. But that's why we were very intentional in this trial to actually focus on clinics or sites that enrich for certain populations. So I would say that kind of, the Apollo 2BA is definitely enriched for veterans, which kind of disproportionate minority population. Northwestern is, I think, a strong African American population. I would say the Providence really represents kind of what a more community health center would look like. And the Cedars population is actually over 30% Hispanic. So that we're hoping that each of those sites can serve as some validation of its external validity, but we haven't gone so far as to test across, I think, subgroups in each site.
Perfect. No, I think, it's hard to really build trials that really can do that. I mean, we would love to do that, but it's harder to do. And again, one of my final questions in all of this, and, I don't know how we're doing on time, so maybe I'm faster.
One more would be perfect, and then we can move to Q&A. Excellent.
Perfect. So is the idea that, you clearly one of the things is you had champions at 5 sites and the number of sites you have, the champions are there. How do you think about scaling nationally? Because a clear answer is that, say this, I mean, we all hope that, and wish that it's a widely positive study that allows us to really think about a new paradigm in diagnostics for amyloid. But what's your strategy on commercial, academic, scaling? How does that interplay work for stuff you're developing right now?
Yeah, no, it's a really great question. I think that particularly for this use case, there are tailwinds, by which I mean that there are many new therapeutics that are currently being investigated and on the market, so that there is a large, I would say, marketing and awareness push by life science companies. Because of that, I think that we have talked to some life science companies as used as a clinical trial enrollment augmenting tool, right? They're interested in having more patients being identified earlier as part of their clinical trials for clinical trial enrollment. And also, even some of these life science companies are helping different centers start up amyloid-focused clinics, right? I think that heart failure cardiology is an area where actually there's an increased interest in cardiac amyloid, particularly for new graduates, and they're often trying to build up their own clinics, so that this is a very complementary tool where that's an area where I think many healthcare systems have particularly disproportionately, and I think that healthcare always has limited bandwidth, but disproportionately this is an area where there might be more bandwidth than other use cases.
Perfect. No, thank you. And I moved the mic over to Matt.
Awesome. This is amazing. I can attest as a fellow cardiologist, it's just incredible to have two, pioneers and leaders in AI and cardiology, being able to listen to sort of a fireside chat on this topic and in the context of David's project. So we have some excellent, so thank you both. We have some excellent questions in the chat, and I'll just start with the first one by Triva T. And David, please feel free to respond. And Rohan, if you have, comments after David responds, please jump right in. This is intended to be a conversation. So Triva asks Dr. Ouyang, have you worked with any imaging system companies such as GE, Healthcare, Philips, et cetera, to accelerate the commercialization and distribution across the US or even the globe of these tools?
Yeah, no, this is a really great question, and I think it speaks to a little bit of kind of what Rohan was also asking with the last question. I think the port of entry for a lot of these systems to have the biggest impact, I think, is on the level of the modality or on the level of the PAC system, right? It's very hard if you have to go to every hospital and ask, oh, can we run this? It's much easier to deploy if, there are a couple of large PAC system vendors or there's large couple of modality, meaning the ultrasound cart vendors to use this. That's an area we're definitely interested in exploring. They tend to be large companies, so that they have a thorough due diligence process. Hopefully, this kind of prospective evidence is the kind they'll need to show that this can provide value to their healthcare partners. But I do think that that's really one tremendous way to increase scale.
Excellent. The next question, and again, if people would like to ask questions from the audience, verbally, just raise your hand and we'll call on you. This is from Lisa Lehman. Thanks for your important presentation. Can you elaborate on how you are assessing your algorithm for bias, and how did you decide on the threshold of 0.8, which I think you alluded to a little bit earlier?
Also, fantastic question. Cardiac amyloid is known to be underdiagnosed in the African American population. I think that a couple of our sites do not have a large African American population, Cedars included, but we do check, at least initially, even prior to the prospective piece, are we actually disproportionately identifying or not identifying African American population? But as I mentioned with kind of the conversation earlier with Rohan, is that the numbers for cardiac amyloid are so small that by sheer statistical noise, it might be enough to have some heterogeneity across sites. So that a big effort for us is to really focus on just having diverse sites that really shows diverse practice patterns and patient populations. And the threshold of 0.8 was really to, particularly for something that's a rare disease, to prioritize specificity so that we can have more buy-in in each of our institutions when the downstream partners see that actually we are getting more patients with amyloid, as opposed to saying they're screening 10 patients, giving one positive.
Excellent. Well, I think the next question dovetails on that nicely. This is from Daniel Yang of KP. Can you tell us more about your outreach strategy for those that exceed the 0.8 threshold? What are you telling them to drive engagement, and what are the follow-up actions? And then also, what's the system's bandwidth to accommodate these patients?
Yeah, it's a fantastic question. I think it really gets to brass taxes. Of the patients greater than 0.8, we actually chart review those patients. So at Cedars and some of the other sites, it's done by a cardiology fellow who is also working in tandem with a heart failure specialist that focuses on amyloid. I think that that is going back to the bandwidth question. For many of the sites here, except the VA, generally not capitated systems, so that these amyloid clinics are interested in seeing more patients, and this is really part of their ongoing clinic efforts. We usually start with a video visit, so that's low, I think, effort on the patient or provider side. We call the patients and we say, hey, we've had this new AI screening tool. It doesn't mean that you have cardiac amyloid, but we're interested in having you see a provider to see if they'll review your chart more thoroughly, and if necessary, order downstream testing. And then we let the provider decide, actually, I have no idea what this is thinking. I think this is unreasonable. I don't want to order tests. You're like a 19-year-old. That has not happened, but that will be in their prerogative. Or they can be like, actually, looking at your chart, you have carpal tunnel and you have other reasons. I like to order a PYP test and do this downstream testing, our usual standard clinical workflow. So the vignette that I highlighted earlier in our talk is actually our first positive at Cedars. We've actually screened 3 patients with PYP now, and this is the first positive, but it really speaks to kind of, I think we're early days, and that patient was started on targeted therapy just this last month on tafamidis. The follow-up questions are usually, we hope that because they're in a specialty clinic, it's whatever is standard of care for that specialty clinic. Our amyloid experts generally in most of these sites are enrolling for clinical trials, so we leave it up to them if they think that it's valuable or helpful for them to start a clinical trial or to be started on therapy like tafamidis.
Let me ask a follow-up question to that. Is it a part of your aim, or do you imagine a follow-up where you could, after evaluating, the effectiveness of, not just the algorithm, but the workflow in different systems, then merge, potentially create a more predictive tool that uses a combination of EMR elements? If you combined the data that are in the EMR with what you're seeing on echo to kind of streamline that evaluation process.
Yeah, no, it's a really great question, and I don't think there's a right or wrong answer. Generally, and I think this is also a good question for Rohan. But my guess is that in general, we strove to single modality tests or algorithms because it actually increases the envelope of patients, right? Like if you have 4 sites, all the EMRs are different. The VA uses CPRS, even if you have different flavors of Epic, it looks very different. The practice patterns of how one even writes the notes or documents or kind of bills is so heterogeneous that we worry that actually introduces more noise without significant value in terms of screening for patients. Whether it's kind of EKG or echo, by limiting it to one ingestion modality or kind of input data, it makes it just much easier on practical level to have that implemented.
Yeah, I mean, I think it's definitely more practical to go after a single modality. I would certainly say I am a little biased towards doing a little bit of we have a study that actually David's part of. We're doing AS screening this way. We're going to do AS on ECG and then AS on echo, and it's hopefully getting NIH funded this summer. And the idea is that we're going to do sequential because we feel that there may be more yield in that. So if there is more yield, I think there is value to go. But if one test is just so much better and it's like doing well, then maybe there is no value in just do that specific test. And I think, in this example, it seems to be working well and has a large enough catchment area, especially with the goal of restricting false positives. And I think that if you the more modalities you go to, you might get into trouble with like getting more people in who may not have the disease.
Yeah, and at a conference that Dave and I were at last week, someone brought up a good point about the fidelity of physiologic testing data relative to potentially the fidelity of data within the EMR. And they used the term of human hallucination as opposed to, say, like LLM hallucination, where sometimes things in the chart may not always accurately reflect, what is true for the patient, whether it's diagnosis that's too general or a diagnosis that's been copy pasted over time, but maybe even has been ruled out. Excellent. So another question, this is very specific to amyloid. When doing from Orest Boyko, when doing PET brain imaging for amyloid, should we also be doing whole body PET, looking for cardiac deposition?
Yeah, it's a really great question. The PET brain imaging for amyloid is usually in the setting of Alzheimer's disease, right? Because there's kind of tau, amyloid deposits in the brain. A slightly different type of imaging for cardiac amyloid. And even that has many different subtypes of the different types of proteins. So kind of TTR or wild type or kind of genetic variants of TTR is the most common that's found by bone sensitivity or PYP tests. Generally, whole body PET is not the standard way to look for protein deposition. And there's a long tail of things that it could potentially miss using that modality. And I think that this ties in similarly with, I think, Tria's question, where for TTR amyloid, that tends to be a disease of the elderly, or even in genetic kind of drivers, kind of genetic variants of TTR, still a little bit on the older side. I am not a pediatric specialist, but I'm not sure if I've ever seen it. That's a good question, if it ever happens in children, but I think it's even more rare.
I would say in the older age spectrum, even like, an early to middle age is actually also unusual. Again, we might be surprised by what we find eventually, but that's the norm right now.
Great. And we have another question here from Mary McGuire. Going forward, how do you suggest that clinicians evaluate AI decision support algorithms? Not everyone can understand the implications of the various threshold targets that are set.
Yeah, it's a really great question, and I think that there's definitely both pros and cons in terms of binarizing. Before our clinicians and in part of our clinical trial, we simply show suspicious or not suspicious at that binary threshold. Obviously, binary thresholds loses information, but as you mentioned, um, there's a lot of detail and almost kind of rational choice designed to kind of to think through it. And it's an area where it might be daunting for the average initial user if we just give them a number and then ask them to think, right? Even in a lot of our clinical decision risk scores, things like CHAS2 VASCR stuff, we usually binarize to a certain number or to a certain threshold, even if we can, say peek under the hood and see what the underlying number is.
Great. We have another question from Tommy Wang. Have you started thinking about an economic case for this type of diagnostic workflow / algorithm in terms of research and innovation? When do you think is the quote unquote right time to think about an economic case versus the impact to patients, impact to science, et cetera?
Yeah, no, it's a really great question. And I think that part of the tailwinds with new therapeutics for cardiac amyloid is an area that makes this both exciting and potentially complicated. By which I mean that these targeted therapies actually have a morbidity and mortality signal. It's clearly good for the patients, but they are also expensive. So I would say that kind of how to model that, as well as how to model what happens when patients are found earlier versus more patients are found potentially in the screening tools, all important implications for different healthcare systems and payment models, right? I would say that kind of KP, where it's capitated, maybe has different incentive structures versus other places where at a private cardiology clinic, you also do more echoes, do more MRIs, you see patients more frequently, so that there's a slightly higher incentive to kind of see patients earlier. Ultimately, it's clear that these drugs have a good patient impact, but where the burden is economically is a much more challenging question to answer.
Great. I have a question that's been on my mind since watching your presentation here. Being a cardiologist, I understand the difficulty of discerning whether an echo is, say, HCM or amyloid or even AS with a lot of LVH. And you kind of showed in your slide deck how you used different sets of controls to help the algorithm differentiate it. For those of us like myself who are not computer vision experts, can you kind of tell us, like, what is the computer doing? What is it thinking to try and differentiate and identify, saying, hey, this is amyloid versus those other diseases that may look kind of similar-ish on echo?
Yeah, no, it's a really great question. Another question that people often ask is like, is it shortcut by LVH, right? And that's one thing that we really try to avoid or prevent by actually, to the extent possible, matching them by wall thickness. To the first approximation, vision models tend to be very good texture assessors and estimators. So I would say that the same way that kind of we knew historically that like amyloid has a starry night pattern on echo, I think that is the most likely signal or the strongest signal that the echo is showing for cardiac amyloid. We've tried a variety of both video as well as image-based models. They work similarly, and this really highlights to me that it's really texture-based as opposed to motion. But again, a lot of the one of the Achilles heels of deep learning is it's a little bit harder to directly identify what are the features that are most relevant.
And I can add that, what people are doing more and more is, there is a push towards science for interoperability that allows us to get a little closer, and specifically, morphing images to like really mask out areas and see whether they were predictive has been a key area to like look through. But in the end, I think all these techniques are designed to just make sure it's not looking at the top right corner and finding it's done in the ICU, and less so on picking up like specific cues that can turn it into a score. Although, there are some examples where that is possible.
Excellent. Well, all right. Well, we have time for one last question before we say thank you and sort of promote our next session here. And Daniel asks, Rohan, given your role at JAMA, and I could say, David, your role at NEJM as well, what are your thoughts on how we promote more of these types of prospective trials?
Hey Daniel, how are you doing? I saw Daniel last year at Sales, so I don't know if he's at Sale right now. So I think thanks for that question. I would say we are working very hard, but as a journal, what does working hard mean for this? It's like we promote the idea that prospective trials in AI should be done. We advertise that we will take them, and we also make sure that we will review them fairly and actually give them the essentially the understanding that this is not a phase 3 randomized clinical trial for a drug, that the bar will be different as long as it's done rigorously and it's not biased. I think we will. So I think those three things we're doing, we're writing aggressively about it, we're advertising our interest in them, and we're making sure we have a reasonable standard for these studies. David,
any thoughts?
yeah,
Yeah, well, I completely agree with everything Rohan says, and I think that, as you can tell, there are many venues that are very interested, and this is similar with, I think, both what the symposium was thinking about. The last piece I'll add, and I think this highlights Rohan's point, is that a lot of AI researchers are interested in clinical trials, but it might be the first time. The piece that I most highlight, if at all possible, and we've unfortunately had to reject trials that we really liked but didn't do this, is please pre-specify your endpoints, put it on clinicaltrials.gov, and then really show that you're doing this without kind of post hoc analysis. And that's something that I think I'm sure many of the journals care about, to show that it's a rigorously done trial.
Excellent. I want to thank Dr. Ouyang, Dr. Kara for this stimulating, exciting discussion. I want to thank everyone for joining, and please join at the next symposium. Mark, do you want to share some closing thoughts?
Just thank you, everybody. Looking forward to seeing folks next time. Thank you, Daniel, David, and Rohan.
Thanks so much. Thanks for having me. And great job, David. Thanks.
Yeah, no, thank you, Rohan.
Bye-bye.
Good seeing you, and good seeing you, Matt.
Have a great rest of your day.